بسم الله الرحمن الرحيم. This is our comments on the breast cysts. I have put on the group many cases. Some are simple cysts, some complicated cysts, and some complex cysts. So this is a short talk on the breast cysts and how to manage, how to recommend in your report, mainly ultrasound report, of course. Breast cysts are extremely common and are present in most women over 40 years old. Breast ultrasound allows its detection and correct diagnosis of the cyst. Typical simple cyst is anechoic. The simple cyst is anechoic, thin-walled with posterior enhancement and edge shadowing. This is the typical appearance of the simple breast cyst. Regarding the clinical presentation of these cysts, either the patient if it is large cyst like this, the patient will come with a breast lump, or sometimes with pain, and sometimes with, if she has fibrocystic breast disease and known, she may have newly developed lump or pain in one of these cysts. At ultrasound, the breast cysts are categorized as either simple cyst, as we just say, thin-walled with posterior enhancement, no internal echoes, completely anechoic, or complicated cyst, as in this cyst there is diffuse thickening of the cyst wall. This is the thickened wall of the cyst. So this is a complicated cyst, and I remember that this case she's coming with pain in that area. So this is an inflamed cyst and she should take antibiotic with follow-up like any inflammatory condition. Then the complex cyst, which contains solid and cystic component or thick septi, and we will analyze it more in the coming slides. So this is this is the cystic lesion, but here there is a solid component with vascularity inside. So Doppler is mandatory in order to differentiate between vascular solid component, which means that it is a growth, it is a solid component, or just debris, which is common also in the breast cysts like galactocele and hematoma. You find echogenic component mimicking solid component, but it is not solid because there is no vascularity within. Appropriate categorization is important because the management of each type differs. This is the Peyret's classification of cystic lesions. Category 1 is the simple cyst, imperceptible wall, anechoic content, and posterior enhancement. And those, we give them Peyret's 2. But we need also follow-up. In the new lexicon, we can give Peyret's 2 and say follow-up after 6 months in order that there will be no newly developed lesion that is not benign. And we always tell the patient that. Regarding a complicated cyst, thin-walled, or the presence of echogenic content, I put the diffuse thick wall with those. From my experience, I can put diffusely thickened wall with those category also. Echogenic content, fluid level, and posterior enhancement, those I can give Peyret's 3 for follow-up. But also to me, if the patient is not complaining and it is just coming for screening, for example, and we found these cystic lesions and some of them echogenic with fluid level, no problem. We can give it 2 also because there is no problem in that. But if the patient has pain or turbid content or newly developed pain or redness, then mostly this is inflammation, and we can give antibiotic and give her Peyret's 3 for follow-up after proper treatment. There is a very small incidence of malignancy of these lesions, but if you're sure by Doppler that there is no vascularity, then you can give it 2. Complex cystic and solid mass, thick wall more than 5 mm or thick septa more than 5 mm, or the presence of intracystic mass, cystic component with Doppler. Doppler is very important, and solid cystic mass more than 50%, the solid lesion more than 50%, those of course, we must give them pyrex 4 and 4 biopsy. We will not stay, we will do biopsy just. This is the pyrex classification, and then we have this classification also here apparent. What are the differential diagnosis of the lesions in different categories? In simple cysts, we may have simple cyst, galactocele. Early galactocele and early hematoma can be completely anechoic. But of course, in galactocele, you can find it in lactating female, and you find communication with the duct. The oil cyst also is one of the categories that put under the simple cyst, but in the oil cyst, we didn't find this posterior enhancement in most cases because it is oil, so there is no good sound transmission. Then here the complicated cyst, also we can put galactocele and hematoma and oil cyst and abscess. Here we can put the abscess in the complicated cysts with internal echoes, with the 6 septi, all we can put abscess in these lesions. In the complex cyst, also we can put galactocele and hematoma, but take care on Doppler there is no vascularity. There is no vascularity, and since there is no vascularity, we can go back to them as a complicated cyst. And so also the fat necrosis, sometimes the fat necrosis may give an impression of malignant nature, so we must take care. Abscesses, necrotic tumor, papillary tumor, atypical ductal hyperplasia, and ductal carcinoma in situ, all these can, intracystic carcinoma, which is rare, only 1% of cases, but we must take into consideration. So this is the differential diagnosis of the different breast cysts. This is the typical simple cystic lesions. It may be just simple cyst, as we say, or sometimes we have microcystic appearance. This microcystic appearance, this is type 2, like these lesions, clustered microcysts, but this is, and sometimes I found some of you reporting clustered microcysts as pyrad 3 or being suspicious. No, they are not pyrad 3, they are pyrad 2. They are clustered microcysts, just you have to adjust the gain, be sure that there is no solid component, and then they are type 2 cysts. And then type 3 cysts, you find cysts, but it may be bilocular and there is septi inside, but this septi usually less than 5 millimeter. In complicated cyst type 4, you can find fluid debris or fluid level, echogenic debris inside. This is type 4 complicated cyst. To me, these cysts, if there is no complaint, I put it 2, not 3. According to my experience, because I followed many fibrocystic breast patients, many of them have this appearance and there's no complaint, and when I follow, they are the same and they are stationary course. Okay, type 4 and type 5 and type 6, complex cystic and solid lesions, those that we give them pyrex 4, thick wall cystic mass more than 3 millimeter, septi greater than 0.5 millimeter in thickness, microlobulated in parts, mass echoes intracystic, and no posterior enhancement, and color Doppler positive. This that we give pyrex 4. Those who need core needle biopsy or clip and removal, definitive diagnosis is the surgery. Maybe atypical papilloma, papillary carcinoma, metaplastic carcinoma, malignant phylloid tumors, all these may be complex cystic and solid. Complex breast cysts are associated with a variety of benign, atypical, and malignant pathological diagnoses, including fibrocystic changes, intraductal papilloma, abscess, hematoma, fat necrosis, and fibrocystic mastopathy. Here we have this septations and this thick part, so it is a complicated cyst. And you note here it is focal thickening, not diffuse thickening as we see in the first case. So when there is focal thickening, you must put Doppler, and you put it at least pyrex 3 for follow-up. Complicated cysts contain low-level internal echoes, intracystic debris that may layer and shift on change of the patient position, like in this case, it's fluid level here. This is a case of chronic abscess. We put the chronic abscess in the category complicated cyst. Here there is a appearance like solid component, but it is not solid, it is an echogenic debris inside. And there is a wall that you see here, there is a wall, it's not a solid, it is a wall seen here. So it is a thick wall, so this is a chronic abscess. To be sure, you must put Doppler. Here is the Doppler. Here is the Doppler, there is vascularity in the wall. This is noise, of course, because there is moving particles inside. And one sign also, if you put the probe and do allotment like that, you can find moving particles inside this abscess cavity. So this is a chronic abscess. Of course, here the lymph node also differ from the case that I put you before, that there is diffuse thickening, and this is common with the chronic inflammation, and the vessels coming from the hilum, so this is not suspicious. And here again, this is not suspicious. The vessels are not coming from the hilum. Some will say that this is focal thickening. No, if you change the image and try to give the length of the lymph node, you will find it like that, diffuse thickening. Complex breast cyst, this is also a cystic lesion, but it shows solid component with marked vascularity, malignant nature, lack of arborization. So this is here, it's very suspicious, not suspicious only. It is a very suspicious, you can put it 4C. Complex cysts have thick wall, thick septi, intracystic masses, or discrete solid component. Like that, there is a discrete solid component, you have to put Doppler. In this case, there was a vascular pedicle sign, so it is a polyp or يعني papilloma, intracystic papilloma. Here this is a malignant abscess. In this case, there is non-uniform thickening or predominantly solid lesion and with cystic component inside. Mostly this was a tumor with necrosis inside, so it behaves like a malignant abscess. This the necrotic part, and this is the solid component outside the lesion, so this is central necrosis rather than cyst. By using the criteria adopted by Berg et al. In 2010, we can categorize the complex cystic lesions into type 1 masses which have thick outer wall, thick internal septa or both. Type 2 masses contain one or more intracystic masses. Type 3 contain mixed solid and cystic component less than 50%, and the type 4 more than 50% solid component with eccentric cystic foci like we have seen in the previous slide. Here, this is type 1 complex cystic lesion. There is thick septa and the focal thickening of the wall and internal echoes inside. Here there is cyst with focal vascular thickening. Here there is focal thickening of the cyst, and this focal thickening is vascular. Here. So it's by right for biopsy. There is vascularity within this focal thickening. Here. All this thickness. Again, solid component with thick septi. In this lesion, it is a complex cyst. There is a solid component, thickened septi more than 5 millimeter, and the wall here is markedly thickened also. So this case, thick septi, vascular, so it is by rights for biopsy. In this case, it is a lactating female. There is no vascular solid part. No vascular solid part. So this is not 4, this is pyrite 3. But sometimes you can find hyperemia in the wall, maybe infected, maybe due to that she is lactating, so there is hyperemia in most of the breast. So this is here. This is the echogenic part, and this is a galactocele. So this is a galactocele in a lactating female. Another case, this female was 14 years old with retroareolar painless mass and here is the findings. So this is not complex cystic and solid. This is echogenic, fibrin-like or proteinaceous material insipiciated inside. It was strange for her age. This vascularity is not in the lesion, it is in the wall. When you get Doppler at the extremity of the lesion, this is the wall of the lesion. So don't put it as vascularity in the lesion. Like in the lesion here is not vascular at all. So this is an avascular lesion, and I put it pyrette 3, and on follow-up it was the same, and there is no vascularity inside, and then the patient removed it, and it was a galactocele also, and no atypical cells. This case is different. It is a solid component with vascularity inside. There's vessels inside. This is a heterogeneous solid component. This is type 3 because the solid component is less than 50%. And then here, this is the solid component. When you put flow, there is Doppler flow inside. So this is complex cystic and solid complex cyst type 3 and pyretes for biopsy. Here also, this is type 4 complex cyst because the solid component is more than 50%. And here we can see nicely there is intraductal extension towards the nipple. There was intraductal extension towards the nipple, so this is highly suspicious. This is pyretes 4C. Another case, a cyst with complex solid component more than 50%, so it is a complex cyst type 4 and high vascularity on Doppler, so it is pyretes 4 biopsy. This is the IL cyst. The IL cyst here, there is no posterior enhancement as I told you, but it is thin-walled, or sometimes it contains echogenic knob inside. But sometimes the fat necrosis may be irregular and may be mistaken for malignancy. But this is the most common cyst seen with fat necrosis. Also post-operative changes and post-operative seroma you should consider when you talk about the complex cysts. And this is a complex cyst lesion with debris inside, but it is just a seroma and there is no recurrence. So post-operative seroma, we must also comment on it is a complex cystic lesion. For interventional diagnosis strategy, if we have typical cyst, type 1, 2, or 3, then it is pyretes 2 and there is no follow-up requirement, or you may require follow-up just to take care that new masses will not develop. Symptoms such as pain, palpation owing to very large cyst, we can do aspiration if she has pain from this cystic lesion. Just or she can take treatment. In complicated cysts, as I say, if the complicated cyst is not, if the patient is not complaining, there is no pain, there is no fever, then you can put it with the pyretes 2 lesion. If there is any complication or the patient has pain, then we can do follow-up. If there is pain and we suspect that this cyst becomes inflamed, she can take antibiotic and come for follow-up after 2 weeks or 1 month. If not, there is no pain, then for 6 months follow-up. Then type 5 and type 6, we can do core needle biopsy, cystic mass or complex mass. This is type 4 biopsy, whatever category as we have classified. Very, very important in complicated cyst is to ask the patient history, to see the patient history. Is just coming for screening, or she has just felt a lump, or there is pain and fever, suspecting inflammation. So the patient history is very important to put your pyretes category. We don't all the time depend on the literature, just the literature said that. Depend on your experience and try to make your own experience on the cases. Thank you very much. I think this better to take very short literature on a specific subject. Thank you for listening.